The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi everyone. So for today, we'll be talking about the abdomen specifically, a little bit of histology, but more on the anatomy as its main focus. Okay, start. So for the anterior abdominal wall muscles, it's important whenever you're dealing with these is to know the different layers of each. So the first one would be your external oblique. So your external oblique, it is said to be the largest. It is said to be the most superficial of which, when you go down your external oblique, it has a free inferior margin, and you call that your in that inferior margin is called your inguinal ligament, also known as your Poupart's ligament. Okay, Poupart's ligament. Now, underneath your external oblique, no brainer, it's going to be your internal oblique, and it's described to be something that is going upward in a medial sense. Now, underneath it would be your transversus abdominis muscle. Your transversus abdominis muscle, previous board exam question was which of the following is a flat muscle, which is a description of your transversus abdominis muscle, a flat muscle. Underneath it would be your rectus abdominis, your abs, and then your pyramidalis, which is only seen in about 80% of the people, is a very important muscle that tenses your linea alba, which is an important landmark as well for median abdominal incision during your cesarean section. I'd like to point out here that your internal oblique as well as your transversus abdominis, they form your conjoint tendon, also known as your Henle's ligament. Okay, and this is important because your conjoint tendon, as you know from your general surgery rotation, that they use that as a landmark in doing hernia repair. In your conjoint tendon, if there is weakening there, then it definitely would lead to an herniation. Okay, next off, we have the anterior abdominal wall layers. So the anterior abdominal wall layers, I would just want to point out here, is these two things, which are often confused by students. You have the superficial fascia. You have underneath it two types of layers, your Camper's fascia and the Scarpa's fascia, two eponyms. Your Camper's fascia is known as the fatty layer, as opposed to the Scarpa's fascia, which is a membranous type of layer. And the way I remember this is when you're going into camping, it's going to be a bit cold. You need a little bit of fat or adipose tissue. Kaya lang siya nagiging fatty type of layer. That's how I remember it as my mnemonic. It's also very important that the Camper's fascia later on will merge with the superficial fascia of the thigh, as well as the perineal fascia. Okay, the deep fascia, on the other hand, that would cover most of the muscles, and it continues over the spermatic cord as your external spermatic fascia. It continues over the penis as Buck's fascia, which is another eponym. Buck's fascia is also known as the deep fascia. And for the perineal area, it's going to be the deep perineal fascia. Okay. Now, let's move on and talk about arcuate line. So the arcuate line is basically a crescent-shaped line marking the inferior limit of the posterior layer of the rectus sheath. So why am I talking about this? Your arcuate line is a very important marker when we're dealing with the rectus sheath in itself. The arcuate line is said to be in the midway between the umbilicus as well as your pubic crest. Now, having said that, your rectus sheath is divided in two portions. You have the anterior rectus sheath as well as the posterior rectus sheath. Mainly, the anterior rectus sheath superior to the arcuate line is going to be made up of the aponeurosis between the external oblique, which is this one, and the internal oblique. Now, interestingly, anything above the arcuate line for the posterior rectus sheath, the internal oblique muscle also gives rise to an aponeurosis to it as well as the transversus muscles. But anything at the level below the arcuate line, the aponeurosis of the internal oblique, the transversus abdominis now pass anteriorly to form the anterior rectus sheath, leaving there the transversalis fascia as the sole sole component of the posterior rectus sheath. Okay, so the most posterior portion, anything below the arcuate line, would only be your transversalis fascia. Now, the inguinal triangle is also known as your Hasselbalch triangle, and there are different boundaries that sometimes students have a hard time remembering. But you have to always remember or look at pictures in order to memorize this. Let's say for this inguinal triangle, the inferior epigastric artery, which is this area that I'm highlighting, is the superior and lateral border to it. The inguinal ligament or Puppart's ligament, which is in the inferior portion of your inguinal canal, is the inferior and lateral portion, whereas the rectus abdominis muscle is the one that's medial. It's actually the lateral border of the rectus abdominis muscle that forms the medial border or the medial side of the Hasselbalch triangle. Now, why are we talking about this? It's because your inguinal canal is an important site for herniation. Just a brief recap, your inguinal canal is around 1.5 or 1.5 inches long and 4 centimeters long. So in the boards, they can either use the inches or the centimeters. So you have to memorize both, unfortunately, or you can just do like a little conversion whenever you're taking the exam. So it begins on the posterior area from the fascia transversalis, which is a hole here in opening of the inguinal canal. So this is from the fascia transversalis. It's a versalis. It's a hole in the fascia transversalis, and then it goes beyond to form the hole in the external oblique aponeurosis as the superficial inguinal ring, which is this one I'm highlighting right over here. It is definitely going to be parallel and immediately just above your inguinal or your Puppart's ligament. Okay. Now, a question that came out, or a clinical vignette that they may ask you is, a 2-year-old boy presents with pain in his groin that has been increasing in nature over the past week. He has been found to have degenerative malformation of the transversalis fascia during development. Which of the following structure is most likely defective in the anterior abdominal wall? The answer here would be letter B, deep inguinal ring. And the reason for that is because, as I mentioned earlier, the hole in the transversalis fascia is the opening of your deep inguinal ring. And then a little bit of crossover for this is that you always have to know the difference between a direct and an indirect type of fascia, and which population would have it more. So a direct inguinal hernia is usually found within an older population, and if it's a younger population, I would usually think of an indirect type of herniation. A direct, the mnemonic here is T, stands for daddy, which are in the more senior type of group of people. Okay. Now, let's go to the peritoneum. Just the peritoneum is basically a glistening transparent serous membrane with 2 continuous layers, and those 2 layers are going to be your parietal and your visceral. I guess the more important thing here is to know that the parietal layer is very sensitive to heat, to cold, to pain, to pressure, basically what you feel on your skin area. And therefore, if a patient comes in with peritonitis, mainly in the parietal area or mainly involving the parietal peritoneum, then their pain will be somewhat localized. And that localization oftentimes is referred to C3 to C5 area, either in the shoulder area, let's say for gallbladder problems, as opposed to a visceral peritoneum. The visceral peritoneum is insensitive to touch, to heat, to cold, but it's stimulated primarily by stretching. Okay, and therefore the pain will be diffuse and poorly localized. And that is the basic concept as to why the appendicitis in appendicitis, it will usually start off as a periumbilical pain because you're only touching the visceral peritoneum until so much so that it travels down later on to become a more localized right lower quadrant pain. So it has something to do with the peritoneum as well as the pain receptors, whether it's more sensitive to touch, to heat, to cold, to pain versus a more poorly localized type of pain. So there are peritoneal organs. There are also retroperitoneal organs. You have to memorize. You pick one to memorize, and that would be more efficient for you during your board's review. Primarily, if it's retroperitoneal, that's what is mostly memorized. There are some mnemonic. This is a mnemonic given by Dr. Vibar, but I also used another mnemonic. It's called your SAD pucker. So your SAD pucker, your S there, it's going to be the suprarenal or your adrenal glands. Your A there, that's going to stand for your aorta as well as your IVC. Your D there, that's your duodenum. The duodenum, primarily, it's going to be the D2 to D4. Remember that the superior portion of the duodenum is not retroperitoneal. So it's not the entire duodenum that is retroperitoneal in that sense. You also have your P, which is the pancreas, except for the tail portion of the pancreas. The tail portion of the pancreas is within the peritoneum. You also have the ureters for you. The C there is going to be colon, primarily the descending and ascending type of colon. Recall from your anatomy lab when you're doing your dissection that when you open the abdominal area, the ascending and the descending colon has this covering within it, as opposed to the transverse that was kind of like hanging within the abdominal wall. And when you open the abdomen, when you open that abdomen, so that will make it more of a retroperitoneal type of location. Okay, you also have your kidneys, your esophagus primarily in the thoracic portion, and R would be for the rectum, but the rectum, just remember that it's only partially retroperitoneal in that sense. Okay, so the peritoneal cavity, it's basically a space in the parietal and the visceral layers of your peritoneum. There is somewhat like kind of like a lubrication within the within the peritoneal cavity, and approximately per day you have 50 cc that is being produced of fluid within it. Okay, again, there are no organs in your peritoneal cavity. Now let's talk about the foramen of Winslow. The foramen of Winslow, or your epiploic foramen, is also known as your adytus. And it is an opening between the greater sac and the lesser sac, or your omental bursa. If you put in your finger, then you imagine what are the borders that are making up your foramen of Winslow. You have there the anterior hepatoduodenal ligament. You have posterior to your finger, it's going to be the IVC. Inferior to it, it's going to be the superior part of the duodenum, which is your D1. And the caudate lobe above it, which is the superior portion of the border of the epiploic foramen. Why am I talking about this? Your foramen of Winslow is very important because surgeons can actually do a maneuver called your Pringles maneuver in order to control the bleeding from a hepatic inflow source, whether it's going to be from the portal vein or the hepatic artery. That's going to be the inflow source versus the outflow, which are your hepatic veins and your IVC. Okay. Okay, so you also have your peritoneal reflection. There's mesentery, there's ligaments and omentum. Just remember that the mesentery, it's a connection in a hollow viscous to the body wall, as opposed to the omentum, which is more for connection to the stomach area. Okay. In omentum, you have two. You have the greater omentum, which is known as your abdominal policeman, especially for patients with perforation, with any abscesses. Oftentimes, the greater omentum would act as so-called as a policeman because they would contain the infection in that area. Okay, then you also have your lesser omentum, as I mentioned. So the lesser omentum is made up of two types. You have the hepatogastric ligament and hepatoduodenal ligament, which contains your portal triad. And if you remember going back to your surgical rotations, for hepatobiliary surgeon, they're going to use like an ultrasound just to view the Mickey Mouse sign. And the Mickey Mouse sign is what is your portal. It's referring to the portal triad, mainly if this is the Mickey Mouse sign in the ultrasound, the one that is in a posterior area is going to be the portal vein, and then anterior to the right will be the common bile duct, and then hepatic artery lying anterior now towards the left area. Okay. Now, moving on, we now have the esophagus. The esophagus is 10 inches or 25 cms long. Your esophagus is one of the areas in the body that they like asking about the measurement. Just remember, it's one of the 10 inches. It's a recurring theme in the body that you would have around 10 inches for other portions. I'll mention that later on. The esophagus is an organ that starts off at the C6 of your cervical vertebra. So that's kind of like the transition point from the larynx going to the esophagus. And then once it's within the C6, it will now become a muscular esophagus going down until you reach your T10, where the diaphragm hiatus will be seen. And important also for the esophagus is that its attachment is from your phrenicoesophageal ligament. Now, with regards to the esophagus, what is peculiar about this is that it has different arterial and venous supply, and the names would differ in each of the section. Recall that your esophagus has three segments. You have the upper segment, which will be subserved by the inferior thyroid artery from the subclavian vein, as well as the inferior thyroid vein. No brainer, it's the same name, inferior thyroid artery, inferior thyroid vein. Coming off to the middle area, here you would have esophageal arteries from the aorta, as well as the azygos vein as its venous supply. Lastly, you have the lower esophagus. The lower esophagus now has arterial supply from the left gastric artery, and its venous supply is the left gastric vein. Again, these two are no-brainer, same name, except for the middle one, which has the esophageal arteries and the azygos vein. More than knowing the name, you have to know where it actually came from. It can come from the either from the aorta or from the subclavian veins. You have to be, or the celiac trunk, so you have to know where it actually originated. Okay. Now, just so you know that there are three anatomic and physiologic constrictions of your esophagus. You have the upper, which is due to the cricopharyngeus muscle. You have the middle, which is where the aortic arch and the left main bronchus would cross its anterior surface, and the inferior within the esophageal hiatus before it enters before it merges with the stomach area. Now, there are several numbers here. You have your 15. You have your 15. You have I remember this as 25, just so it's in the multiple of 5, and then 40 centimeters here. Now, why are these numbers important? It's because when you put your OGTs, your oral gastric tubes, or any tubes down there, you remember that they have lines there. So when you would know where you are if you just subtract and you memorize these numbers. So hey, I'm on the upper pharyngoesophageal area, or I'm on the thoracic or diaphragmatic. So you know when to stop placing those tubes down the patient's esophagus. Okay. Okay, now we talk about the stomach. So the stomach is around 1.5 liters in capacity. This is in contrast with newborn babies, which only has 30 cc's in total. So the parts of the stomach here, you have the cardia. The cardia is the region following the Z line of the gastroesophageal junction, on which part there will be transition of the epithelium from a stratified squamous to a rather columnar type of cells. Another thing for cardia is that here in cardia, this is where they place the gastric band when they're doing, like, let's say, bariatric surgery, just to deter the patient from eating more in that aspect. So you have your cardia there, you have your fundus, which is the curved area, the body, which is, by the way, you have two curvatures there. You have your lesser curvature towards the right side, and then the greater curvature towards your left side. Okay. Now, let's talk about the duodenum. The duodenum, anatomically, it is located in the L1 to L3 region. Now, it is the first part of the small intestine, and it is also the shortest part of the intestine. Even if it's a short part of the intestine, it actually is divided into 4 segments. You have the first part, which is known also as your superior duodenum, and it is 5 centimeters in its measurement. You have the second part. The second part, what you need to know and to expect here is that the second part of the duodenum has a major duodenal papillae, to which your pancreatic secretions, your gallbladder secretions are actually being dumped into. You also have the third one, which is essentially going to be crossed by your superior mesenteric artery. In between the superior mesenteric artery and the third part of the duodenum is a fat pad. Now, what's the clinical significance of that? In patients who are losing a lot of weight, or let's say patients are anorexic, the fat pad would be gone, and therefore the superior mesenteric artery would pulsate towards the duodenum area, and therefore they would have obstructive symptoms. They would be very aversive to food, so much so that they may become, malnourished in that sense, further deteriorating their nutritional well-being. And this is known as your superior mesenteric artery syndrome. Okay, it's usually due to low body weight or malnutrition. And that's basically like an anatomic crossover to a clinical setting. Now, the fourth part of the duodenum also is where the ligament of Treitz is seen. And that ligament of Treitz is an important landmark for considerations of upper GI bleeds versus lower GI bleeds. Okay. Now, you have here your gastric versus duodenal ulcer. Basically, in an anatomic standpoint, gastric ulcer is oftentimes caused by left gastric artery bleeding, as opposed to a duodenal ulcer, which is gastroduodenal type of artery. Now, how would you distinguish this in a clinical setting? If it's a gastric type of ulcer, they will be producing more abdominal pain when the patient takes in food, as opposed to a duodenal ulcer, which is you would have lesser abdominal pain with intake of food. And the reason for this is because when you take in food, then patients would have more bicarbonate secretion, decreasing the acidity in that area, decreasing the abdominal pain that the patient is having. Now, Importantly, there's a hallmark for duodenal ulcer. Commonly, patients would wake up in the middle of the night, so that's one of the hallmark, as also mentioned by Harrison's. For patients with duodenal ulcer, there's a higher risk for malignancy for patients with gastric ulcer, definitely. Okay, so to remember the difference between the jejunum and the ileum, I'm not sure if they asked this in the recent boards, but they did ask a couple of questions during my time about the difference between the jejunum and the ileum. I apologize. There is no mnemonic for I don't use any mnemonic for this one, but if you do, you can shoot me an email and then we could probably share it with everyone else. But basically the mnemonic or the thinking I have is to differentiate jejunum versus the ileum is that a lot of the absorption happens in the jejunum area, and therefore they should have a wider, thicker walled membrane just to carry the absorption process. It will need more vasculature, and therefore it's going to be redder in that sense. With regards to fat, it absorbs the more important quote unquote nutrients, leaving out the dirt and the fat behind. And that being said, when you go to the ileum, you would expect thinner walls because it doesn't absorb as much. You would have dirt there, which are your fat depositions, more fatty substances within the layers of your ileum. And not only that, is that there are aggregations of lymphoid tissue, and the aggregations of lymphoid tissue there makes sense because you're dumping dirt there, and the body would need to protect itself from these potential pathogens. Okay, that's how I remember it. Now we talk about the pancreas. The pancreas anatomically is within a T12 and L3, and the reason why it spans this area is because it's diagonally placed in our body, so much so that the tail is within the T12 area and the head is within the L2 and the L3 region. Now the head is the one that is an expanded part. It is embraced by the C-shaped curvature of your duodenum, which is this area right over here. And then you have a very short neck that overlies your superior mesenteric vessels. You also have there the body. The body on your other hand is towards the left portion of your SMA and SMV, and the tail area, which is touching the hilum of the spleen. Now, important thing to remember here is that the tail of your pancreas is found within one of the ligaments. It's called your lienorenal ligaments or splenorenal ligaments within your abdomen. Okay, so let's talk about pancreatic ducts. You have two main pancreatic ducts. You have the main, two types of pancreatic ducts. You have the main pancreatic duct, also known as the duct of Wirsung, and then you have the accessory pancreatic duct, which is the duct of Santorini. If you have a main pancreatic duct, it's called main because it spans throughout the entire length of your pancreas, and it empties into the duodenum. This is in contrast with your Santorini, which only lies within the head portion and drains into the main duct. Now let's talk about the liver. The liver is the largest visceral organ. The liver is around 1,500 grams in its weight. It is said to be dome-shaped, and it is definitely surrounded by the peritoneum, but it has what you call the bare area. Okay? The bare area is where it's devoid on the diaphragmatic surface. You also have two vasculatures that are very important here. Your portal vein, which usually supplies 70% of the blood, as opposed to the hepatic artery, which only subserves around 30% of oxygenated blood. So you have there your portal vein, which is 70% of blood, hepatic artery, which is around 30% of blood. You have to know that the portal vein, the portal vein is a union of the splenic as well as the superior mesenteric vein. Okay, and the hepatic artery is actually a branch of your celiac artery. Now, why am I talking about this? Because the liver can be divide it into functional segments. You have there your 8 different segments, and each of these 8 segments, whenever you do your hepatectomy, would it basically you would be able to remove even one portion and you still have a functioning type of liver. I will point out that there are 8 functional segments, and the 2 that can be asked, or let's say more likely to be asked, would be the caudate lobe, which is also known as your third liver, coinoid segment 1, versus the quadrate lobe, which is coinoid segment 4B. Okay, so the caudate lobe is actually between right of the IVC and porta hepatis. Okay. Now, this is the portal lobule. Histologically, there are different types or classification for the portal lobule. You have here your hexagonal type. You have here on the basis of the zones. Now, I would direct your attention towards the zone area, just because I feel like it's a more important concept that you have to master as well. There are a lot of clinical vignettes that can be thrown into you when you study this. The main general principle, especially when you're studying anatomy, is number 1 is to memorize. I apologize for this, but unfortunately, there's no other way but to memorize these structures and always correlate it clinically so that it would make sense in the long run. Anything that you are able to correlate clinically will most likely be a high yield topic to know. That being said, going back here, you have your zone 1. The zone 1 is known as your periportal zone. The zone 1, the periportal zone, is going to be affected first by your viral hepatitis, and it is best oxygenated. Okay? The zone 2 is intermediate. Now, if you're asking me, Bradley, is there anything important with your intermediate zone? There is actually. If you've heard of the disease yellow fever, they like staying here in zone 2. You have zone 3, also known as the pericentral zone. What's up with the pericentral zone? The pericentral zone has a characteristic that is first affected by ischemia, mainly because it's farthest from the blood supply, and it has a lot of CYP450. I'm sure you've heard of CYP450 from your biochemistry class. So it regulates a lot of these toxins that goes through our liver. Okay, so let's talk about the gallbladder. The gallbladder is a pear-shaped organ, and it contains 30 to 50 cc's of gall fluid. Now, it is made up of different parts. Remember, the gallbladder doesn't have a head. They like asking that question, putting it as a false statement, like the gallbladder is composed of the head, the body, and the neck. That's actually a false statement because it should be technically a fundus. Now, the fundus, the tip of the fundus, lies within the right 9 costal cartilage. And it also is in contact with a transverse colon. 2 high-yield board exam concepts that has been asked over time. You also have the body of the gallbladder, and then later on the neck. Within the neck is an eponym known as your Heister's spiral valves, which can open and close, depending on the situation for the gallbladder, and it is where most of the cystic lymph node is also located. Okay. Now, what about the cystohepatic triangle? Cystohepatic triangle is also known as your triangle of Callot. You have different boundaries for this. You have the superior, which is the liver area, the inferior, which is cystic duct, which is this one, and then your common hepatic duct. What is the clinical significance of this? Your cystic artery from the right hepatic is oftentimes seen here. Now, that's common. That's going to be like, everyone will know about this, but they may ask you about the percentage. So the answer here would be 62% of the time, anatomically, it will be found in the cystohepatic triangle. And then the rest would be like an anatomic variant to it. The large intestine is made up of the different parts. You have your cecum, which is, by the way, the widest and the most dilatable as per Snell. You have there the appendix. You have there the colon. The colon in itself is made up of the ascending, which, by the way, is said to be retroperitoneal. You have the transverse, which is usually one of the longest, the descending, retroperitoneal, and the sigmoid area. Okay? Just writing it down here that it's the longest. And then you have the sigmoid, which is the narrowest. Okay? Then you usually would have blockage within your sigmoid area. Okay? Talking about the appendix, it's a worm-like blind intestinal diverticulum with mesoappendix. It is 3.5 inches in length, and majority, when you try to open the patient up using your McBurney's point, 64% of the time, it's going to be retrocecal in location. Okay? To locate the appendix, you would follow the taenia coli from your intestine, and it would lead you towards the base of the appendix. Now, whenever you do your appendectomy, there is a nerve called your iliohypogastric nerve that is oftentimes iatrogenically injured as well. When it's injured, you would have weakening of the abdominal walls. So another clinical concept that is also high yield to remember. Now, talking about your types of diverticulum, we have also here your Meckel's diverticulum. The Meckel's diverticulum is a very famous true diverticulum of the stomach, mainly because it involves all the layers, and there's a very good mnemonic to it, which is highlighted here for us to learn. You have here, it's 2 feet from the ileocecal junction. It occurs about 2% of the population. It is 2 inches long and contains 2 types of tissues. Can either be an ectopic, gastric, pancreatic, or a mixture of both. There is also a ratio for this one, 2 versus 1. 2 males get it more versus your female. So that's the ratio for this one. To diagnose your Meckel's diverticulum, you have to use the Meckel's scan or your Pertechne's scan, which is I believe it's an isotope that the nuclear medicine or the imaging people use for this one. Now, your Meckel's diverticulum is often a complaint commonly seen in kids as well. They would complain of GI bleed. Okay, so let's talk about the transverse colon, which is also an important one. Again, it is the longest and the largest and the most mobile. Longest, largest, most mobile among them all. And this is suspended with a transverse mesocolon from the anterior border of your pancreatic area. Again, the transverse colon, by the way, has a connection with the gallbladder. It touches your gallbladder. And if you look at through your BRS anatomy, when you're trying to answer there's one question that would actually ask about that. So you have to know sometimes which organ touches which and what's the clinical significance. Because sometimes, when you get inflammation with your gallbladder and you touches your transverse colon, then it can erode into that area as well. Talking about that, going down, we have your anal canal. The anal canal, you have the dentate or the pectinate line, which is the boundary between the superior and the inferior parts. Within it are the anal columns of Morgagni, which are, if I'm not mistaken, they're 6 to 10 in numbers. Okay, then you have 2 sphincters there. You have the internal anal sphincter and the external anal sphincter. The internal being involuntary and the external anal sphincter being the voluntary one. But what I want to highlight here is that the pectinate line is a very important clinical tool because it would differentiate what the patient will be experiencing. Because usually, if you have, let's say, a mass or like external hemorrhoids, patient will complain of pain, especially if it's below the pectinate line, because there is somatic innervation right down there. as opposed to the visceral, which is a more of a diffuse type of pain for patients with internal hemorrhoids, unless it is, of course, touch the somatic innervation later on. You do have the arteries, which are also different. This is the superior rectal artery, a branch of your IMA, versus an inferior rectal artery, which is a branch of the internal pudendal artery. Okay, IMA, internal pudendal down there. The veins are also differ. This is the superior rectal vein. Here, it's the inferior rectal vein. And the reason why this is important is because the vein above the pectinate line drains towards a portal vein, versus if you go below the pectinate line, it's gonna be through the your central IVC. And more importantly, the drains of your lymphatics is also different. Here, if you have cancer, it's going to be the internal iliac. Here, it's superficial inguinal together with some parts of your genital. So they drain together in the superior inguinal lymph node. Now, the abdominal aorta starts at T12 but ends at your L4. It is known as your bifurcation. Remember, it's 4, L4. It is where it should bifurcate into the iliacs from the abdominal aorta going down towards your iliac. Okay? Now, talking about the vasculature here, I just want to highlight that in the aorta, you have the celiac trunk. The celiac trunk is a very important trunk because it subserves a lot of the vasculature in your stomach and your liver area. And there are 3. You have your left gastric, you have the splenic, as well as the common hepatic. The left gastric artery is the smallest and it's the first branch, and it gives rise to the vasculature supplying the superior half of the lesser curvature of the stomach. Now, another crossover to general surgery is the marginal artery of Drummond. The marginal artery of Drummond is an anatomic variable vessel that is a network between the superior and the inferior mesenteric artery. Now, I would also like to introduce you to a concept known as the arc of Riolan, which is also your I'm forgetting the name. I think it's mesenteric meandering artery of Moskowitz. So the MMA, or the mesenteric meandering artery of Moskowitz, is also an anastomosis between the superior and inferior mesenteric artery. Now, if you're gonna ask me, Bradley, hey, those are two similar descriptions. They are a network, an anastomotic network between the superior mesenteric and inferior mesenteric. So what's the difference? So the marginal artery of Drummond actually is an anastomosis in the mesenteric border. In contrast with the arc of Riolan, which is the base. It's the mesenteric base. So this is the mesenteric border. This is the mesenteric base. The way I remember this, if it's a D comes before your R. So Drummond is in the border, base or end of the alphabet would be your Riolan. Now, inferior vena cava, the inferior vena cava is formed in the union of 2 common iliac veins behind the common iliac artery. Again, important anatomic crossover is that it will start off in the 5th lumbar, or your L5. And it would pierce your diaphragm at your T8 area. Okay? Now, what about your portal caval anastomosis? So you have your veins, you have the portal system, and then the IVC, which is your caval system. Now, the normal route here is that from the portal vein goes through the liver, hepatic vein, draining to the caval system entirely. Now, problem is, let's say for patients with cirrhosis, there can be blockages, and these blockages would manifest as let's say, engorgement of your portal cavern anastomosis, there are actually four. You have your gastroesophageal anastomosis, which is between the esophageal branch of the left gastric, as well as the esophageal of your azygos, the left gastric being the portal, and the azygos being the caval anastomosis. Now, if the patient has, let's say, liver cirrhosis, and therefore there will be definitely blockage in the portal caval because of the high pressures within the liver, then you would have gastric esophageal bleeding brought about by the obstruction. If a patient bleeds out, you're suspecting of upper GI bleeding, you give them definitely fluids, you give them omeprazole, you give them a large IV bore needle, then it should be a 2 large IV bore needle. Anyway, so that's just a little bit crossover with IM. And then you also have the anorectal anastomosis, which is the superior rectal that I was talking about, that is above the pectinate line, and then the middle and inferior rectal below it, but it's an anatomical anorectal anastomosis that can produce like hemorrhoidal protrusions in your anal canal. You also have the paraumbilical anastomosis, which is from the veins and the anterior abdominal wall. And I believe this is the Medusa head that you are able to see in some patients who are in the later stage already of their end stage, in the later stage of their liver disease. You also have the retroperitoneal anastomosis within the retroperitoneal organs, as well as some of the phrenic veins. And that explains, and this is the reason why some patients with cirrhosis, they have aversion to food as well. They will complain of early satiety, and this is brought about by the retroperitoneal anastomosis, that sometimes they are engorged, they're not having enough blood flow to it, and therefore they will get easily full with just even little meals because they're not digesting it well. Okay, so the posterior abdomen, let's go now from the vasculature going towards outside the muscles, going down. You have your posterior abdominal wall muscle, you have the muscle of the loin, which is the psoas major. The psoas major is the action here is it flexes and lateral rotation of the thigh at the hip area. Then you also have the iliacus, which it on the other hand flexes and externally rotates the femur. Here, externally rotating the femur. And then you have your quadratus lumborum. The reason for which is it's because it's quadrilateral in shape. Not such a high yield muscle to remember. Then you have a very important organ that is your spleen. So the spleen is lying within the diaphragm and to the 9th and 11th ribs in the left hypochondriac region. The reason why I'm bolding the 9 to 11 is because this is a very important concept for trauma in patients who underwent trauma, or traumatic like NVC or an MVA, a motor vehicular accident or a collision. Oftentimes, the clinical vignette will tell you that they have rib fractures in the 9th to 11. You're going to think of the spleen area here. The spleen is covered with peritoneum except for the hilar area. Another important clinical correlation with the spleen is that the spleen is taking in, like, I think about a third of your RBCs. It's also very important if a patient has cirrhosis, mainly because if the patient has cirrhosis, then there will be platelet sequestration within the spleen area. And therefore, patients will manifest with low platelet just because there is high pressure within the in patients, or portal hypertension in patients with cirrhosis. Okay, histologically, your spleen, it is composed of your white pulp and your red pulp. The white pulp here is a site, it's called the white pulp because you think of white blood cells. The white blood cells, these are immune phagocytic cells. You also here have the Malpighian corpuscle. Then you also have the red pulp, which is made up of venous sinusoids. Okay? And this is where our worn out RBCs are being filtered out. Okay. Okay. Now we move on to the kidneys. Anatomically, it's found in T12 to L3, and it is closely in contact with your psoas major. There are three structures that enter and leave the hilum, and they love asking this, like the anatomical arrangement of it, wherein the renal vein is the most anterior, then you have the renal artery, and then the renal pelvis, or the start of the ureter, being at the most posterior area on this. Okay. Now, I also want to touch about the different capsules within the renal area. This is something that is quite annoying to study, but they do ask this. So if you look here, the yellow portion that's being highlighted, that's going to be your kidney. The next layer to it is the renal capsule. The renal capsule is the true capsule of the kidney. Next to it would be the perirenal fat or the perinephric fat. Perinephric, when you hear the perinephric layer, perirenal, it's actually basically the same thing. It's a fat covering the renal or the fibrous capsule. Okay, next would be the renal fascia. This is known as the eponym Gerota's fascia. So your Gerota's fascia is a fascia covering it, but it is devoid inferiorly. So if you're gonna do, let's say, a kidney surgery, you might enter to the inferior portion just because it's gonna be devoid of fascia in that sense. Okay. I believe the Gerota's fascia is the one that encloses the kidneys as well as the suprarenal glands, and it's continuous throughout in the bilateral portion of your abdominal area. And the thing here is that infection may travel from one point, from one of the renal fascia towards another renal fascia. So you have to be very careful of that in patients who are presenting with abdominal abscess. Then lastly, which is the pararenal, is the covering to the entirety. It forms the retroperitoneal fat. Again, if this is a kidney, the first layer would be the true capsule. That's your renal capsule. Next would be a fat, a perinephric or a perirenal fat. Next would be the true fascia, quote unquote, because this is what we always know about the Gerota's fascia, which is devoid inferiorly, and then later on the most outermost portion would be the paranephric fat, which is also known as your retroperitoneal fat. Now, the blood supply of your kidneys comes from the abdominal aorta at the level of your L2. And it breaks out into these little arteries, starting off from the segmental artery. From the segmental artery, it would go as your lobar artery. So this is your lobar artery, your arcuate artery, interlobular later on, these small branches branching out, and then going towards your afferent glomerular arterioles. Okay? Now, the venous drainage, on the other hand, drains in front of the renal artery, and it goes towards your inferior vena cava. Okay, so this is kind of like the end point of it. Okay, so a little bit of a clinical correlation. The right renal artery is longer than your IBC, and the left renal artery courses posterior to the left renal vein. The left renal vein, on the other hand, is longer and passes between the superior mesenteric artery and abdominal aorta. Now, during renal transplant, the incision will be placed anterior to the abdominal wall, just above like the inguinal ligament. And then usually what will happen is that the renal they will cut it off and then place it to another person. When they place it to the other person, the renal artery is going to be anastomosed to the internal iliac artery, whereas the renal vein is going to be anastomosed to the external iliac vein. Again, the renal artery is anastomosed to the internal iliac artery, whereas the vein, the renal vein, is going to be anastomosed to the external iliac vein. And then usually the kidneys will be placed in the pelvic fossa. Okay? Okay. We're heading towards the end. You have your adrenal glands. You have adrenal glands, which are your 4 to 5 grams. Histologically, you have the glomerulosa, fasciculata, reticularis, and the mnemonic here is as you go deeper, it becomes more pleasurable. You have your salt, sweet, and sex. Salt because of the aldosterone, fasciculata sweet because of the cortisol, and reticularis sex because of the androgens. Now, interestingly, anatomically, your blood vessels here are also very different well, it has a lot of blood supply to it. So you have the superior adrenal artery, superior artery, superior suprarenal artery from your I believe it's inferior phrenic. You have the middle suprarenal from the aorta in itself, and then you have your inferior, which is from the renal arteries. Okay, again, superior from the inferior phrenic, the middle from the aorta, and inferior is from the renal area. The venous drainage, you have the right adrenal vein, which drains into the IVC, versus the left adrenal vein, which drains into the left renal vein first, then goes towards your IVC. So that's kind of like different. Also, I think an important a difference between the two. Okay, so this is what I'm saying earlier, that the blood this is for the ureter. So the ureter also has different blood supply each of the area. If it's within the abdominal area, it's going to be the renal from the abdominal aorta. If it's within the pelvic, as it courses through, it's going to be the gonadal from the abdominal aorta. And if it's within the bladder already, it's going to be superior vesicle. The corresponding venous drainage are very similar as well. You have renal, you have your gonadal, and then the superior, inferior from the internal iliac vein. Okay, so 3 constructions for the ureter as it on its origin from the renal pelvis, meaning to say right over here where I'm highlighting, you have as it crosses the pelvic brim, and the other, let's say this is the pelvic brim, so that's one construction, and the other as it pierces through the bladder wall. And the reason why the piercing towards the bladder wall is problematic is because there is oblique entrance to it, and therefore you would have somewhat a stasis there in that aspect. Okay, so a little bit of embryology. You have the foregut with its innervation from the vagus nerve as its parasympathetic innervation, whereas the sympathetic is from T5 to T9. The midgut, which is observed by the SMA, has still vagus nerve as its parasympathetic innervation, and it's now T5 to T12. Later on, and if it's in a hindgut, it's going to be via your IMA. And this would be the more different one. I think if you just remember this for parasympathetic for the hindgut, that's going to solve all your problems, because the first two are the vagus ones. You have there your S2 to S4, which are pelvic flank nerves. And the sympathetic here is from T11 to T12. But likely they would, if I were to like just memorize this slide, I'm just gonna memorize S2 to S4, which is a pelvic flanking for the hindgut area, because the rest would be the vagus nerve. Okay. So these are just the functions of the anatomic nerves in the abdomen. Just a little bit of correlation with your physiology. I'm sure Dr. Brawley did a really good job explaining the concepts here. That if it's sympathetic, it's more of it's gonna inhibit motility. You don't want to crap yourself out when you're in a tight situation. They do promote breakdown of glycogen and glucose, just because you need the energy, promoting more epinephrine, norepinephrine secretion, as well as constricting the renal arteries. The reason why you constrict this is because you don't want to form urine as much whenever you're in a flight type of or fight type of mode, as opposed to a resting, more parasympathetic type of mode. The parasympathetic, by the way, is just basically the opposite, but it has no effect in the suprarenal medulla. Okay. Okay. So those are actually all my lectures. More of the I nitpick most of the more important topics when we're dealing with the abdominal area. Whenever you're studying for the GI tract, I do suggest or recommend having a netter at your side, or even like the Snell ones, just to kind of like visualize it. The good thing about the GI anatomy is that the organs are really large. It's easier to memorize as opposed to let's say the ear ossicles or whatnot. For it, yeah. So I hope you did learn something about from this lecture, like little tidbits of pieces. It's more of I assume that it's more of a review than just entirely what's this one, what's that. um if you have any mnemonics that you are able to share, then you can shoot me a message, then I can try to incorporate it in the next few slides, or we can send an addendum towards your mentors as well as your MGs. So yun. Goodbye. Have a good day.